My name is Cynthia Harden. I'm a physician and I am the Director of Clinical Epilepsy Services at the Mount Sinai Health System in New York City. I'm here today to talk about the guideline on sudden unexpected death in epilepsy that is coming out, being published in Neurology today. This guideline was co-developed in partnership with the American Academy of Neurology and the American Epilepsy Society. We worked together on this from its inception. The genesis of the guideline really came from a grassroots movement. There has been very active advocacy groups regarding SUDEP from people who've lost their loved ones to SUDEP, and they partnered with the medical community to really try to raise the awareness. So we were approached in the academy to undertake this guideline. And interestingly, it was thought among us who were sort of targeted to undertake the project that there wouldn't be enough evidence to inform a guideline. But when we started looking at the evidence, there clearly was some strong papers regarding the incidence and the risk factors. We chose those specific pieces of information to study and evaluate because they will be the most useful to practitioners in discussing SUDEP with their patients. How often does it occur, and what are the factors that increase the risk? And then with the new AAN guideline process, which incorporates a methodology for developing actionable recommendations, I'm really pleased that we were able to take the assessment of those risk factors and the ones that were strong risk factors and turn them into a recommendation for practitioners on really how to reduce the risk of SUDEP. So another piece of the background on this topic is that doctors and healthcare providers don't talk about SUDEP enough with their patients. This is something that is felt by the consumer community, and it's been sort of avoided by the medical community. And I think the reason for this is actually very human, in that when we provide care for people, we don't like to talk about things that we can't quantify or to mitigate or treat or manage or provide any reassurance or comfort. So with the body of knowledge out there about SUDEP, there are many papers discussing the incidence and risk factors. Some of the papers have long lists of risk factors, some of which are modifiable, like, perhaps how many seizures do you have? That's potentially modifiable. Some of the factors are not modifiable that were looked at, such as gender. We undertook through the process a way to really understand which of those risk factors are strong that would drive a recommendation on management, and which are really not strong enough to incorporate into a recommendation. And so there were really only a few that rose to the level of helping us develop a management approach. And these are not mysterious. I think they're intuitive. The neurological community has known about these, really. It's having generalized tonic-clonic seizures, which is the most severe form of a single seizure involving all four extremities, clearly loss of consciousness. It's the sort of classic seizure or convulsion that the lay public would definitely think of, but it's really the most risky seizure type. It is the main seizure type, and in our analysis, the only seizure type that truly is associated with a risk of SUDEP. Now, one thing that may come to mind is why. And we did find supportive information as to why that could happen, that this powerful physical event, can lead to a suppression of breathing afterwards. And this could lead to basically death. So if you can prevent that cascade by preventing seizures, that's where we see the intervention. There were actually some very good high-level papers that surveyed in a population-based manner, which is the highest level of evidence we can get for incidence, the occurrence of SUDEPs. And we found about 1 in 4,500 per year for children and approximately 1 in 1,000 for adults. So it goes up. The rate of incidence goes up coming out of childhood into adulthood. The reasons for that are not completely clear, but it might have to do with surveillance. Because I think one of the most important things that came out of our analysis, our guideline process, was that nocturnal surveillance for convulsions, for generalized tonic-clonic seizures, monitoring for those seizures during the night, having somebody in the room with that person who has a generalized tonic-clonic seizure during the night can reduce the risk of SUDEP. So I think this is one of the most important findings that we were able to put forth. And the actionable recommendation from that data is you should consider having someone in the room or having a monitoring device in the room with a person who has generalized tonic-clonic seizures during sleep. This is not a complicated, fancy, expensive way to reduce SUDEP. And so that's one of the, I think, most important things that came out of our guideline. For understanding the rate, now we have a number. Practitioners will be able to say, you know, this is your risk. To say your risk of a family with a child with epilepsy, your risk is on average 1 in 4,500 chances of dying per year. It's rare. It's honest, but maybe reassuring. And then in adults, about 1 in 1,000. But this discussion can then be followed up with the ways to reduce risk, such as reducing the occurrence of generalized tonic-clonic seizures through partnering in management. If this drug or if this approach is not stopping these types of seizures, we have to try another one. You have to incorporate with the patient their preferences. Is epilepsy surgery appropriate? Is that the next avenue? And I think that now we have a lot more ammunition to get patient buy-in about reducing the risk of SUDEP as well, because it's a partnership. The patient and the physician, they have to be on the same page. You know, if this isn't talked about, they're not going to get on the same page. So I think we made some fairly strong recommendations. The nocturnal surveillance, it's a recommendation that we qualified with the word should. You should consider this intervention, but we have to keep in mind it's not practical for some people. It's not something that we can say you must do, but it's something certainly that we found reduces the risk of SUDEP. So many of the risk factors did not reach a level of strength of evidence that people have been thinking about, talking about. Is it a specific drug? Is it a specific type of epilepsy? Is it MRI abnormality? Is it intellectual disability? None of those things really rose to the level of being able to make a strong conclusion on the strength of the evidence or form a recommendation. Keeping in mind, it may not be useful for us to develop a recommendation on something that's not modifiable. So I think that we really provided a lot of useful information to inform that very necessary conversation. How often does it occur? If it does, if you do have this risk of generalized tonic-clonic seizures, particularly during sleep, how can we reduce them? We put forth a strategy, and we finally really tried to send a strong message to to practitioners who take care of people with epilepsy. Keep trying. Don't settle for even 1 generalized tonic-clonic seizure per year, if at all possible. And I think that's a strong message for the neurology community. It's something that I'm actually really proud of this AAN process. I'm really hoping that this will be useful. We don't tell people from our guideline process how to talk with patients. That's not part of what we do in the AAN guidelines, but I think this information is easily translatable to a conversation that could be life-saving.